So I was going to talk about chronic kidney disease update, and the focus of my talk, a little bit different than Omar's, was around clinical trials from around the world. I thought I'll go through a little bit of a quick whiz around some of the current data and significant trials. One second. Sorry, which one is it? Wonderful. Okay, sorry, slight delay. So what I was going to cover in the next 15 minutes or so was to go through the epidemiology and the burden of chronic kidney disease. Why is it important? What should we be focusing on? And then the importance around early detection and management. And then the focus of the talk will be around some of the key clinical CKD trials impacting on clinicians and overall broader patient care. So why is CKD, chronic kidney disease, important? We know it's a progressive condition affecting up to 10% of the global population. This amounts to over 800 million population worldwide, and the greatest burden is in low middle income countries. So when you look at the global burden of disease, as I've mentioned, a lot of the burden of chronic kidney disease is in low middle income countries, and this is demonstrated here. So particularly in the Caribbean and also South America, but also in Middle East, North Africa seems to be growing kind of causes, and certainly in the top 10 causes of mortality. So why is early CKD detection and management important? So CKD is common, as we know, as I've demonstrated, and associated with adverse health outcomes. Early detection is important to improve outcomes, and how can you do that from sort of simple screening? Many of my patients will be completely asymptomatic until very later stages of CKD. So CKD stage 4, which is then leading into CKD stage 5, needing dialysis and transplantation. Until then, many patients are completely asymptomatic. We know inexpensive treatments, particularly in the earlier stages of the commonest causes of primary CKD would be diabetes and hypertension. So management of those early will reduce the risk of progression and decrease the loss of kidney function loss early. In particularly low middle income countries, we know this is resource poor, so renal replacement therapy is often unavailable or unaffordable. We've looked at population screening. Is that effective? And that's not thought to be effective. Certainly even in the UK, there was a big drive to screen everyone, but certainly that's not very helpful. So the resource should be detected and also sort of managed on trying to manage causes of chronic kidney disease better. So better management of diabetes, better management of hypertension, and integrating that clinical management of the primary causes of CKD and trying to improve outcomes there to reduce the risk of progression. So what I've focused on in the next sort of 10, 15 minutes or so is some of the key chronic kidney disease clinical trials which have been impactful for clinicians in the UK and also globally. Those primary conditions, diabetes, hypertension, which reduce the risk of progression, so you can focus some of the clinical trials on that, and also then the management of dialysis and transplant patients as well. So some of the trials I'm hoping to just give you a brief overview over are the STOP ACE trial, the CLIC trial, which looks at clofazimine in CKD patients, the Advocate trial, the VALAR CKD trial, and then some of the trials in dialysis and transplant patients as well. So the STOP ACE trial, so the ACE inhibitors, as we know, are good for reducing cardiovascular outcomes and improving outcomes for those patients in CKD. But the main question here was, particularly even when I was a medical student and junior doctor, it was always stop the ACE inhibitors, stop the non-steroidals in renal patients. But is that really of benefit? And does that reduce the progression of patients with CKD? So this multi-center randomized trial based in the UK was specifically looking at that question, that does stopping RAS inhibitors, which includes the ACE inhibitors and ARBs, reduce the risk of CKD progression. So the rationale around that is shown on the right-hand side. So if you stop the ACE inhibitors, it may well lower the rate of hyperkalemia, it may improve renal function, it may buy us some time for dialysis access and preparing for transplantation. However, the argument for continuing RAS inhibitors would be the improved cardiovascular mortality, morbidity rates, improving blood pressure control, and also the less need of antihypertensive medications. So this was a multi-center randomized open-label trial looking at this specifically, and over 39 centers were enrolled in the UK. So when you looked at that, the primary outcomes are shown on the right-hand side. So continuing the ACE inhibitors, did that reduce the reduction in the EGFR? So that wasn't any difference. So continuing or stopping the ACE inhibitors didn't make a difference on the EGFR or the renal function. The secondary outcome was the time to end-stage renal disease or requirement of renal replacement therapy. So that, if anything, surprisingly, was actually worse in patients who had stopped ACE inhibitors. So if you continued ACE inhibitors, the time to end-stage renal disease was shorter. And same for major cardiovascular outcomes as well. That was higher in patients who had stopped the ACE inhibitors as well. So the main findings from this trial is that the STOP ACE trial did not find any significant benefit of stopping ACE inhibitors or ARBs in advanced CKD patients. The discontinuation arm had significantly higher risk of needing kidney replacement therapy and also a numerically higher risk of cardiovascular events. So that common myth of stopping ACE inhibitors early actually doesn't impact positively on renal outcomes. If anything, it's negative for cardiovascular outcomes. So certainly there's more benefit for continuing ACE inhibitors rather than stopping ACE inhibitors. So that was interesting. Of course, some trial limitations, which I've shown here. The CLIC trial is the second trial, which I'm just going to give you a brief overview over. So chlorothalidone is a loop diuretic, which has been shown to, as compared to placebo, reduce cardiovascular morbidity and mortality, but there's limited evidence around that in CKD patients. So this was a US-based trial and looked at continuing chlorothalidone in addition to other antihypertensives in patients with hypertension and CKD, and looking at progression of renal disease in those patients. So the primary outcomes are shown on the right-hand side. So did it significantly reduce blood pressure? Yes, it did. Significantly reduced blood pressure in the chlorothalidone group. However, it also improved the proteinuria levels. Proteinuria is seen as a marker of progression of chronic kidney disease as well. So it improved and reduced the amount of proteinuria in patients who were on chlorothalidone. But unfortunately, the last bit, the bit that we were looking at, was whether it improves the progression or reduces the progression in CKD patients. This was not the case. So chlorothalidone as a loop diuretic worsened the renal function in those patients. So the primary findings are shown here. So the main findings around significant reduction in blood pressure, that was done, great. However, the increase in the serum creatinine and the adverse side effects was negating some of these benefits. So on the right-hand side, you can see the reduction in the blood pressure, and then the table at the bottom shows the adverse events, which includes the worsening of the renal function during the treatment period. So certainly not of benefit. And although in pure hypertension patients, it improves reduces mortality and improves morbidity, but in the CKD patients, it didn't affect the progression in a positive way, particularly with all the side effects. The third trial is the Advocate trial. So this was one of the trials that we were involved with. So I lead the vasculitis service in the northwest of England. ANCA-associated vasculitis, we know, is a significant cause of morbidity and mortality. This was an international trial which we took part in. It's a life-threatening condition. Earlier detection management improves outcomes, as we know. And the challenge for a lot of these patients we have is the balance between therapy as well as minimizing the complications of therapy. So there's a great need for targeted therapy in these patients, and avacopan is a newer agent which works on the alternative complement pathway and helps reduce some of the side effects associated with treatment-related therapies. So that's the kind of rationale around it. The trial was an international trial which looked at standard care of therapy, which is steroids, cyclophosphamide, and or rituximab, and then azathioprine for maintenance. And avacopan arm had the reduced dose of steroids, and then the standard care had the normal higher doses of steroids. There's a big push of reducing steroids early, as well as having no steroids for treatment of our vasculitis patients, which is something that we're keen to do. And what this trial showed in particular, that in the avacopan arm, when you looked at the primary endpoints, which is sustained remission at 26 weeks or at 52 weeks. At 26 weeks, it was non-inferior, but certainly at 52 weeks, there was significant improvement and greater remission rates in the avacopan arm. So avacopan was found to be non-inferior to prednisolone with regards to remission at 26 weeks, but superior with respect to sustained remission at 52 weeks. So it's something we are increasingly using in our practice as well. So you've got your standard of care of steroid cyclophosphamide and or rituximab, but we're using avacopan greater. A lot more patients are receiving that with reduced steroids, which will hopefully minimize side effects and steroid-related as well as other immunosuppression-related side effects longer term. Then the further trial is the VALAR CKD trial. So one of the questions is around metabolic acidosis. So a lot of our patients have metabolic acidosis, which contributes to the hyperkalemia as well. And Vivariumab is a new novel hydrochloric acid binder, which removes the additional acid from the GI tract. So this is an international trial, randomized multi-center trial, looking at whether giving this particular agent will reduce the level of, kind of acid, but also increase the serum bicarbonate level, and then whether that in itself reduces the progression of chronic kidney disease. So the primary outcome was looking at whether the serum bicarbonate levels were increased, which they did, and that was significant. However, the progression of chronic kidney disease hadn't worsened, hadn't been significantly affected in those patients. So reducing and improving the metabolic acidosis status did not improve outcomes for or reduce the progression of chronic kidney disease. So great in kind of trial data, particularly for animal trials, but in patients, this was not seen to be as a positive trial. The fourth trial is looking at my temperature. So this is in hemodialysis patients. So we know, sadly, the median life expectancy for our dialysis patients is still 47 months. So 4 years, very sad. Many of our patients are elderly with multiple comorbid conditions and still do very poorly on dialysis. We know interdialytic hypotension contributes to cardiovascular risk, and there is evidence to support that having a cooler dialysate when patients have their hypotensive episodes improves, their symptoms. So this particular trial, which is a Canadian-based trial, looked at whether cooler dialysate for these patients will improve cardiovascular outcome, but also reduce the morbidity and mortality associated with dialysis. So this was a first large-scale randomized controlled trial looking at that. However, when you looked at the primary outcomes, there was no difference in composite cardiovascular outcomes in the patients who had the cooler dialysate compared to those who had the normal dialysate. And if anything, patients reported outcomes, adverse outcomes were greater in those patients. So again, it's just showing that in principle, there's certain things which we may feel are beneficial for our patients, but when you look at it in a trial basis, and particularly with large-scale trials, this was not found to be beneficial. And then this was the best fluids trial. So this is the last trial that I'm going to talk about. So in transplant patients, delayed graft function is a major complication of diseased organ, kidney organ transplantation. And we know normal saline is commonly used as an IV fluid replacement, but this may increase the risk of delayed graft function. So there's better evidence for this selective transplant fluid, which is much more of a low chloride crystalloid fluid solution, which has been shown again in smaller trials to be of benefit in reducing the risk of delayed graft function. So this was a big Australian trial which looked at that. So 800 patients randomized, 400 patients in each arm. Half received the balanced crystalline fluid, other half received normal saline. And this trial, in sort of basic terms, showed that the balanced crystalloid fluid had a lower incidence of delayed graft function as compared with saline. And this is now becoming standard practice. Certainly, we have a big transplant centre in Manchester, and a lot of our patients will have a balanced crystalloid fluid compared to normal saline in their immediate post-transplant care. And this is currently being rolled out across different regions as well, but very improved outcomes, and certainly for patients who are in the initial stages of post-transplant period, it showed to be of benefit. So in summary, chronic kidney disease we know is a significant cause of morbidity and mortality. A lot of our adverse outcomes are cardiovascular outcomes. As Omar was saying, a lot of our care is very multidisciplinary, multi-professional, team-based care. It is more about the patient, holistic management. Patient education is very, very important. Treatment of their sort of underlying causes of chronic kidney disease is of great importance. Diabetes, hypertension, whether it's glomerulonephritis, other causes, trying to detect those earlier, managing those earlier will reduce the risk of progression longer term. It's not about population screening. You can't screen all the patients. We tried that some years ago, and then you pick up lots and lots of patients who may have impaired kidney function, but it's not clinically significant. We know it's a large burden in low middle income countries, and it's significant variation in access to treatment. In my international role, we've visited lots and lots of different dialysis and transplant centres, and the access to care, the access to treatment is still so very poor. So we know many of the trials previously were focused on population screening. We feel that that isn't of benefit, and the focus should be on early detection and treatment of the underlying causes of chronic kidney disease. Some of the trials have focused on patients who are on dialysis and transplant to see what works, which I've showcased here, and there has been significant advances to help improve patient outcomes, which I've demonstrated from some of these trials today. But of course, more work needs to be done to understand the kind of greater burden of CKD and how better we can reduce the risk of progression and improve patient outcomes, particularly in the low middle income countries where the need is the greatest. So I hope that was helpful. Thank you so very much for listening, and we will go to questions at the end. Yes. Thank you.
Thank you, dear Dr. Mumtaz, for this informative update.